Good. Good morning, good afternoon, and good evening. Beyond the pill, the transformative approaches to combat AMR is a joint webinar by AMR Declaration Trust and APUA. AMR Declaration Trust is a public charitable trust founded on the principles of Chennai Declaration, a landmark document and initiative to tackle the challenge of AMR in India. APUA, the Alliance for Prudent Use of Antibiotics, is one of the oldest AMR initiatives in the world. Founded in 1975. 1975, that means many of the members in the audience may not even be born. 1975, by the legendary Professor Stuart B. Levy. After his retirement, the International Society of Antimicrobial Chemotherapy, ISAC, took over the leadership and responsibility of APUA. Stuart's Levy's prophetic warning, and that was made during an era of plentiful antibiotics. And a warning about antibiotic overuse and the emergence of resistance have now come to full fruition. He co-founded and led APUA for 37 years. 37 years. It was the first organization to address antibiotic preservation and continues to provide a strong voice in the field despite the subsequent emergence of many other organizations and groups, including Chennai Declaration and AMR Declaration Trust, addressing a topic which has now become a specialty in its own right, a specialty called antibiotic stewardship. Stuart Levy was a trailblazer, and APUA leads a very strong legacy. ISAC was founded in 1961 in response to the dynamic nature of the subject matter, has focused most recently on AMR and antibiotic stewardship. This panel discussion will be in an interview style, fireside chat format. We will not have any PowerPoint presentation. I'm Dr. Abdul Ghafoor. I'm the Managing Trustee of AMR Declaration Trust, and I'm also the Vice Chair of APUA. Drawing from the expertise across the different regions and specialties, we will explore strategies that range from grassroots implementation to high-level policy changes. The questions by the moderator encompass broad topics designed to spark discussion, encourage exchange of knowledge, and promote collaborative solutions. The panelists are encouraged to interpret and expand upon these questions, bringing their unique perspectives and insights to the force. And we have panelists from around the world. We have Gabriel Levy-Hara from Argentina, Heyman Wathin from Netherlands, Pierre Tatavin from France, Vasan Nagwekar from Mumbai, India, V.R. Yamuna Devi from Chennai, India, O.C. Abraham from CMC Vellore, Dr. Priscilla Rubali from CMC Vellore, Sunida Reddy from Apollo Hospital, Hyderabad, Raksha Bhatt from St. Martha's Hospital, Bangalore, Dr. Aravind R. from Trivandrum. Dear panelists, I will direct the first question to our star panelist, Gabriel from Argentina. Gabriel, is that good morning or good night in Argentina?
Hello, Abdul. Hello, everybody. Thank you for the invitation. Early morning here. A nice winter Saturday morning. Yeah, thank you very much.
Gabriel, with the contrasting challenges of antibiotic overuse in some regions and limited access in others, how can we strike a balance between this access and access of antibiotics?
Well, thank you very much. Yeah, briefly, we have some problems, of course, in Latin America of accessing to antibiotics. We have many issues with, especially with, there are two levels of access. One thing is the access in the population, the community health care, the primary health care, and the other one that it's probably more important is at the hospital level, because at the hospital level, not all hospitals or institutions has the the availability of many antibiotics. So, for example, the new one or the newer, the more expensive ones. So the problem to implement stewardship sometimes is related with the prescribers do not prescribe what they might prescribe according to guidelines, but they have to prescribe what they have in the hospital. And this is a great problem. One of the issues that we try to address in Latin American hospitals with our work of the Pan American Health Organization is to try to make a community or national level or province level buyings of antibiotics so they can share with every hospital at a lower price and the way to make them have the antibiotics. This is one of the ideas. Give the rest to the rest of the panel.
Heyman, you have worked in Vietnam, if my memory is true, and now in Netherlands. So you know the both sides, a developed country and a developing country. What is your opinion on the topic?
Yeah, I mean, it's a complex issue. Indeed, you have excess, so there's too much antibiotics being dispensed in various countries, but also people still dying without having access to antibiotics. So children having pneumonia. So there's still an issue that people need these life-saving drugs. So in the Netherlands, what we see is that we have the lowest antibiotic consumption worldwide, and there's nobody dying because they're not getting an antibiotic. So it's having proper care where you need it in the community, in hospitals. I think diagnostics is a key point that you need. So diagnostics to guide when a person needs an antibiotic or not. But besides diagnostics, because in many countries there will be no diagnostics, and also in the community setting there will be very little diagnostics. But things like C-reactive protein testing can be done at the point of care. We've done a trial in Vietnam. So you can reduce antibiotic use drastically by a CRP test for non-severe respiratory infection. And everybody with a runny nose in Vietnam and many other countries get an antibiotic. So there are some clever things that you can do. A biomarker test like CRP, it's patent free. You can actually develop it for $50. And if people are compliant, it can work. So there are some clever things and strategies that we should do. And not just sort of sit back and say, okay, we need more leadership or more this or that. Of course, we need everything, but also some action and some clever ideas.
Thanks, Heyman. Priscilla, we know in India, we have the real combination of access and the excess, the rich and the poor. How are we balancing this very complex scenario?
So I totally agree with the speakers who have gone before me. And access to antibiotics versus, using them appropriately is a big challenge, especially in a low middle income country, where sometimes in the remote areas, in the smaller hospitals, I guess in the cities and in the tertiary care, it's not such a problem. But when you go beyond the cities, the two-tier cities, and you go on to smaller villages and smaller healthcare settings, that's where it actually is a problem. There is definitely a lack of access to the antibiotics, and there will always be that component where, how do we use antibiotics responsibly in that scenario when your access is actually limited? And I think the key to that is education. And that will probably make an enormous difference to, using the antibiotics that you have responsibly. Even with lack of access in some of the areas, definitely, I think especially in India, it's easy to get antibiotics over the counter. Whether it's intravenous antibiotics like, even the carbapenems or the glycopeptides are actually available, surprisingly, in the remote corners of the country as well. It's possible that we don't have, the newer antibiotics that have come into the tertiary care centers, but definitely there is access to at least, the carbapenems or the glycopeptides. So I think education is key, and, imparting that education from tertiary care, moving it out, creating a ripple effect from the tertiary care into secondary care, which then permeates into the primary care, is probably the key to making a difference, I feel.
Sunita, did Dr. Priscilla mention that we may have deficiency of doctors in many villages, but we don't have deficiency of pharmacies, and there is no lack of access to pharmacies and antibiotics over the counter?
I totally agree with that, Dr. Gafoor. The other thing that we have in shortage is the diagnostic facilities. So you have a situation, particularly in the rural second tier cities and down, where your access to good diagnostic facilities is a challenge. And there is an availability of antibiotics. So because of the lack of diagnostics and the availability of antibiotics, actually, I think there's quite a lot of abuse of antibiotics that happens as well. And not abuse in the sense of the type of drug as well as the dosage in terms of the drug. So I am concerned about that problem. The access is not necessarily the access of the drug itself, the access of the knowledge to prescribe the drug in the right fashion at the right time is a challenge.
So it's not the lack of access, it's the lack of proper access to antibiotic or scientific access to antibiotics.
Yes.
Because in India, antibiotics are of access and access in India. You're not audible.
I said, good morning and good evening to all the panelists from Antimicrobial Resistant Trust. I think I already second with all my previous comments who have come from internationally and from our colleagues from India. There's definitely a huge gap between the diagnostics. I'm lucky to be in a tertiary care center, and I'm lucky to be in a city like Mumbai, where I'm, having all the facilities of, smaller as well as molecular tests available. So for me, it's very easy access to have a proper diagnostic. But I fully second with Dr. Sunita, where in villages or second tier cities, and even cities like Mumbai or Chennai, I would say, where you're dealing with not in a tertiary care center, the diagnostics to get to the right choice of antibiotics is a major hurdle. And I think from what we're dealing with, antimicrobial resistance is probably the rise in the resistance is because of misuse of antibiotics, of not getting the diagnostics correctly and shooting the antibiotics one after the other without understanding where the problem is. I think this gap has to be filled up, and unless we fill this gap, the resistance is going to rise, which is not only in India, I would say in a lot of parts of the world as well.
Again, as Priscilla mentioned, we have got a special lack of access. Can technology overcome this particular conundrum? Can we utilize technology to overcome this lack of access, lack of scientific access? We have got the medications available. We don't have the access to the scientific usage of antibiotic. Can we use technology to overcome this, Pierre?
Yeah, hello everybody, and sorry for my bad connection. I hope you hear me well. It's okay?
Yes.
Okay, so really I think that technology has to improve worldwide, because even if you think about what happened in the wealthy countries like North America or Western Europe or part of India probably, most of the time when we prescribe antibiotics, we are just betting that the infection is indeed related to a bacteria, and we are just trying to guess what could be the bacteria responsible for the infection. And more than 90% of antibiotics worldwide are prescribed without knowing the bacteria that we are targeting. We're just doing bet. So I think if we could have a technology that would be cheap and fast to identify the causative bacteria each time we want to prescribe antibiotics, it would be a very huge step ahead.
So we need low-cost diagnostics that can revolutionize the antibiotic prescription and access. Raksha Bhatt, you are a big enthusiast of technology. How can technology help us in bridging the gap between access and access?
Good evening, everyone. Greetings from Bangalore. Me coming from a background of diagnostics as a microbiologist, what I would want to add is one thing is choosing the right kind of test and the availability of these tests, as Dr. Priscilla and the other speakers have already said. the availability of tests across different sectors from a primary healthcare level to a tertiary healthcare level is the actual problem. There's no uniformity that is seen across the country or across the world in various healthcare settings. So something which we can focus on is a rapid diagnostic test for addressing these antimicrobial resistant genes, which can help us decide the choice of antibiotics. And the second point is, of course, culture reports and simple staining, gram stain, and everything can help us in deciding the choice of antibiotics. The interpretation of these tests is something which we see, which is grossly lacking across healthcare sectors. Not all clinicians are aware on how to interpret a basic culture report. When you look at our undergraduate or postgraduate training, especially in different specialties, these things are not actually taught in practice. And that is something which is actually grossly lacking. And over experience, a clinician learns these points on how to choose a test and how to interpret a microorganism, the relevance of it in a culture report, the ASC pattern, whether it is significant or not significant, and then to choose the dose and the route based on the culture report is something which we also should focus on educating our clinicians and other healthcare sector people who actually use these antibiotics to use the diagnostics in the right way, even after it is available. That is one message that I wanted to put across.
Raksha's message is go back to the basics, not just the modern technology. We need to know how to use the ancient technology, including the gram stain. We all discuss about, Yamuna, we all discuss about the diagnostic stewardship. It's the fashion of the day. So many webinars dedicated to diagnostic stewardship. How can we use this diagnostic stewardship to rationalize antibiotic usage and bring down AMR?
Yes, the diagnostic stewardship is helpful for the people where it is available. Again, accessibility plays a very major role. And diagnostic stewardship would help us to create the antibiogram of that particular setup. And based on the antibiogram, definitely we can prepare the treatment guidelines, either a syndrome-based guideline or a focused organism-based treatment guideline from the specimen where we isolate. So that's the main purpose of having a diagnostic stewardship from lab to the bedside of the patient on treating the patients.
Arvind, your opinion on diagnostic stewardship?
Good evening. I would like to thank AMR Declaration Trust and APUA for giving me this opportunity to be part of this elite panel of discussants. Diagnostic stewardship is actually very important component of any AMR containment activities. But then, when we started this, excuse me, the activities in Kerala around, say, 10 years back, so in the OPD levels, that is where actually we can really focus on the maximal means inappropriate prescription of antibiotics happen in the OPD levels, especially for influenza like illness and all. Then the doctors used to say that they are prescribing antibiotics for ILI because they don't have access to rapid diagnostic tests like in the West. Then this COVID came. COVID was a sort of a pathbreaker or an eye-opening experience for us. It was the first time that in India, for an ILI, we had a molecular diagnosis. So for 2 years now, we knew the diagnosis and we were treating, but still the same doctors were using antibiotics. So we really understood that diagnostic stewardship should be topped up with IEC as well. So they were using this as just as an excuse to say that they don't know the diagnosis. That is why they were using antibiotics. During COVID time, it became apparent that despite knowing the diagnosis, they were using antibiotics. So diagnostic stewardship is a very important component of antimicrobial stewardship. But then the people who are supposed to use this diagnostic stewardship, that is the doctors at the ground level, they should also be made aware of other aspects of AMR as well. Diagnostic stewardship alone is not going to work without IEs.
So there is an access problem, not just in antibiotics, but diagnostics as well. In corporate setup, we have got all kinds of diagnostics, different types of molecular diagnostics, and the ground level in villages, lack of basic diagnostics. Heyman, this is diagnostic stewardship is one of your favorite topics. What's your experience from the global experience of diagnostic stewardship?
Well, I mean, it has to start that you have diagnostics in the first place. And I think, yeah, the archaic sort of culture is still quite important, but you need to really think, okay, what is my context and what do I really want to achieve? So you have to know your goals first. Then you have to think about, okay, what are the a priori risks? So what is prevalent in our society? So for acute respiratory infections, we know there's this much resistance. What do I need to rule it out, or do I need to rule it in? So ESBL in the Netherlands is not so important. It's not as important as in India, where the prevalence is very high. So for us, we need to rule in ESBL to sort of decide on antibiotic, but probably in India, you need to rule it out. So your specificity of the different kinds of tests that you need will be very different in different settings. It's not like one test you can implement everywhere. You have to think as an expert in microbiology, what is clever to use in our setting. Yeah? So you really have to think about what do we want to achieve, what is cost effective, and what will have a positive impact on my patients. So you really have to think about likelihood ratios and all that kind of stuff. So it really needs some expertise to think about it. And so we've talked about cultures and about resistance and testing, and the doctor needs to think about, okay, the resistance result is this, I need to give this. But it starts first with, do I need an antibiotic in the first place? So that's what I tried to say before. So you have to think about biomarkers as well, like C-reactive protein or procalcitonin for stopping, but CRP can be used in respiratory infections to either decide to start in the first place, but only for respiratory infections. Don't think, okay, CRP works for respiratory, can use it for urinary tract as well, because it doesn't work for that instance. So you have to also watch out for use of tests where it's not meant for. So really be quite rigid and have good quality criteria, and also have audits to really know, okay, this institution does a diagnostics according to good practice. So it's also about quality control as well, and sort of checks and balances. Over.
Again, we need the balance of excess and access in manpower, antibiotics, and technology. For example, in several corporate hospitals like my hospital or Priscilla's hospital, we have got almost a dozen infectious disease doctors to do antibiotic stewardship. At the same time, there are villages or several hospitals where there are not enough doctors to do antibiotic stewardship. So we need a balance of this excess and access. How can we use rapid diagnostics for rationalizing antibiotic? How can you utilize specifically rapid diagnostics in the diagnostic stewardship? Gabriel.
Yeah, perfect. Thank you very much. I'm back to the hospital-ish field because we are working much more with hospitals. It's different from the community. But for example, one clear example is in the scenario where we have many carbapenemase producing Klebsiella and other enterobacterials, that we have to make the difference between NGM and KPC, for example. The multi-route resistance is so strong that probably with a broad empirical treatment as ceftazidime, avibactam, anastronam, or colistin, or tigecycline, or fofomycin, probably you are using a very expensive and not easy to reach and to have availability of empirical treatment, and with a multiplex PCR multiplex of a film array or something like this, with a similar cost of one administration on vial, we have the potest, the will of in a couple of hours reducing that antibiotic treatment. This is very important. Hopefully many health authorities and Ministry of Health are taking part of this nice meeting, because really the importance of trying to lower the use of more expensive drugs in scenario where we have no more choices for treatment, and there's really a real pandemic in Latin America, in India, etc. It's very important to keep it in mind. It's not the cost of the treatment, but the speed we can choose the appropriate treatment to make the escalation, and to avoid more and more resistance, and having no further choices in the very near future. Thank you.
So rapid diagnostics can play a big role. You know, Longitude Prize is a £10 million prize, and I'm one of the jury and advisory members of the prize. Over the last 10 years, we have analyzed almost 300 applications from around the world, and some of them are groundbreaking rapid diagnostics. If all this technology, and there are dozens of them, very good, come into the market that will revolutionize the antibiotic usage, that will revolutionize the way how we can identify the right antibiotic at the right time, and at least a few of them are very low cost rapid diagnostics can be used anywhere in the world. Now, Raksha, I know AI is one of your favorite topics. How can we utilize AI and machine learning in improving the rapid diagnostics?
Yeah, so talking about artificial intelligence, we have seen a lot of research happening, of course, over the last couple of years regarding the utility of this in various clinical branches in infectious diseases and antimicrobial stewardship, where AI can help us probably for clinicians right from the start of deciding what sort of infection is this in clinical decision making, choosing the kind of test. If we can design algorithms in institution specific, region specific, based on our data, and have modules which can be incorporated into your guidelines and hospital information systems, it can help the clinician to decide what antibiotics can be chosen for a particular infection. Now, again, here we have to have a lot of collaborative projects with the different sectors. We can look at a lot of softwares that have come to make these decisions for clinicians. A lot of applications are available on your mobile app, and then many software companies have come up with this initiative. Here, what happens is the basic structure of an AI model is that it basically relies on data, and data is something which we all have in enormous amount in various institutions. You have your antibiogram, you have your patient-specific demographic data, you have the choice of antibiotics that can be given, you have guidelines. If this can be structured in a way that you have, it's very similar to your human nervous system, like an artificial neural network. There's something called as deep learning. So you train your systems, the software, to identify common syndromes. Say a respiratory infection, if this is the guideline, which this is a specific antibiotic that is recommended. The more data you feed based on your institution or region specific data, the AI model recognizes that this is probably a recommended antibiotic for this patient category. So you can have your institution or region specific data. You can have a lot of AI programs that can design modules for your own institution. So this is something which is very upcoming. There are many research papers which have published where the AI model is trying to say if this is a particular infection and this is a particular antibiotic that is given, what is the response? So a lot of studies have been under process, and it's actually a very good tool that we have in addition to rapid diagnostic tests. It will help us aid in deciding the choice of antibiotics and diagnosing the infection, but that's not going to replace our clinical acumen. Something which we should look forward to and train ourselves is something I would like to add to this discussion.
So we have a rapid diagnostic, very low cost. You add a drop of urine into the machine, and probably in 15 to 30 minutes, you have got a result that is transmitted to your mobile phone, and an app works on the AI technology that can utilize the global knowledge on antibiotic stewardship. So anywhere in the world, any village, if you have a small machine and a mobile phone, you can utilize the global expertise to interpret the results and use the antibiotic. Again, you need to do the clinical examination yourself and interpret.
Can I make one comment?
Oh, yes, Amen.
Yeah, so just with the PCRs and rapid PCRs, so there's been a recent review in the Open Forum of Infectious Disease that analyzed a lot of studies looking at respiratory infection PCR multiplex panels. It doesn't reduce antibiotics. So etiological rapid assays for respiratory infection don't work. So probably here biomarkers can work, many other things can work, but we should not overestimate the impact of these rapid PCRs.
A very good point, Herman. Can I just clarify, or I will ask Sunita's opinion about Herman's comment. Herman mentioned that it doesn't reduce antibiotic, but just from a different perspective, can it rationalize the antibiotic? Because isn't that one of our other aims of rapid diagnostics?
I am not sure personally what is the right answer to that question, Gafur. But if you think about it, if I know it's an upper respiratory illness and I'm able to find a virus, say, I don't know, influenza or para-influenza, I don't know, it may help me, but as long as I know, if it's influenza, yes, it can help me use oseltamivir. But if it's any other virus, all I need to know is it an infection that is bacterial or viral? So will a multiplex PCR necessarily add any advantage to me at that point in an immunocompetent host? I don't know if it will add. Particularly, rhinovirus is present very commonly in the upper respiratory tract and can be a normal commensal. So if it just picks up a commensal, how is it going to help me? Whereas knowing if, for example, if it's a strep throat or not, there it may help me. For this is specifically if you're talking about an upper respiratory viral infection. But yes, there are a lot of syndromic panels available, which, like you were telling, the low-cost technology is coming up. With the current film array nasopharyngeal swab, I would not use it on a regular basis for all patient comers. I would use it, but in an immunocompetent host or in specific patient population, but not in all of them.
So can I make a comment?
Heyman, is that yes, Vasan.
Having a comment.
Yes, Sunita, go ahead.
Wasn't this having a comment is what I said.
So basically, I wanted to give a live example of a patient who just got admitted with me and how your diagnostics and antimicrobial stewardship comes into the play. So here's a patient who is a chronic smoker, 62 years, came with respiratory distress. He's a case of RA. He's been taking methotrexate and having fever for 8 to 10 days. And, he came with a severe respiratory distress. He was on NIV and finally had to be ventilated because of the severe respiratory distress, not maintaining the saturations. He was put on broad spectrum antibiotics with a carbapenem, a glycopeptide, and also with a possibility, because his X-ray showed bilateral, multiple shadows, and the CT also showed patchy ground glassing opacity. So differential was, whether we're dealing with any opportunistic infection. But here, until we have a diagnosis, we would possibly cover him with, being a smoker and, coming from the community. So after intubation, the next thing was we did a BAL and we sent a pneumonia panel. The pneumonia panel BioFire, which is FDA approved, was negative. So that means I knew that this is not a bacterial infection. We did a respiratory BioFire. All the viruses were negative. We did send for PCR PCP and the PCR PCP came positive. So that immediately in last 1 hour, I have removed the carbapenem and removed the glycopeptide, and he's just on trimethoprim sulfamethoxazole with steroid. So this is a very live example how you can actually not only reduce the cost of the antibiotic, otherwise this patient would have been on 10 days of all these antibiotics, which would have gone for $1 lakh or more than that, also unappropriately being used. So this was a good antimicrobial stewardship using diagnostics, where you spend a few thousands but get the diagnosis correct. I'm lucky, as I said, to be in a tertiary care center where these molecular tests are available. These tests are costly, and the same thing I say, these tests should be available at a lower cost so that can be utilized more to get to the right diagnostic path. Also, now since I'm having a right diagnosis, I'm going to treat him correctly, shorten the duration of the ICU stay, get him off the ventilator and send him home early. So not only correct diagnostics plays a very good role in antimicrobial stewardship, also reduces your cost in the hospital stay, which is a very important part of, again, antimicrobial stewardship. So I wanted to speak with this patient. I just de-escalated just 1 hour back, and I thought I should put this as a right example where I've removed all the antibiotics and just use on trimethoprim sulfamethoxazole, so a single antibiotic, which is for PCP.
An excellent example of rapid usage of rapid diagnostic. And as Vasan mentioned, as in India, especially in immunocompromised patient population, making the right diagnosis at the right time it doesn't just reduce antimicrobial resistance, it reduces the cost of care significantly. For a patient with neutropenic sepsis, severe sepsis, we use a combination of antibiotics because we are potentially treating carbapenem-resistant infections. And we go for combination of antibiotics. The cost of care is very high. And if you can get the right diagnosis, it can significantly reduce the cost of care. Now, coming back to Heyman, when Heyman made the statement, it doesn't reduce the usage of antibiotics. That's based on published evidence, and Heyman will have a definite reason for that. Heyman, would you please explain what was the finding of the paper?
Yeah, I'm talking about the cartridges. So I'm not talking about all kinds of combination of tests. I mean, the PCP test is not in the cartridge. So I'm talking about the implementation of all these sort of commercial testing with certain choices of viruses and bacteria. That's where they did a review, a meta-analysis, and there's no evidence it will reduce antibiotic use. I don't say we shouldn't do diagnostics. It's a different thing. Of course, you should have a PCP test if in the case of an HIV patient with pneumonia and increased LDH and so on. So diagnostics are key and crucial. I'm just saying we should not overestimate the impact that particularly these respiratory PCRs have in cartridges commercialized in helping us to rationalize antibiotic use. That's what I'm saying.
Yes, Heyman's point is very good. Even though these rapid diagnostic, respiratory rapid diagnostics are very useful, we should not overestimate its significance. Again, the diagnostic stewardship plays a very significant role in respiratory rapid diagnostics. Now the popular topic, I'm sure, we have been discussing about the impact of COVID, AMR, and still it's a controversial topic. People believe COVID has increased the AMR rate, and people believe in some areas AMR antibiotic usage has increased, and some areas antibiotic usage has reduced. It's a very complex topic. Gabriel, what is your experience in Argentina during the COVID time, and now what's the impact of COVID on AMR and antibiotic usage?
Yeah, thank you. First, I was answering also to Heyman, so was my rise before, and it's related with the COVID. Yeah, now I understand what is saying. Can you hear me? Yeah, it's okay, no? Yeah, can you hear me?
Oh, yes.
Perfect. It's related to your question. We were talking, for example, about PCR multiplex, but it's another important thing that also was important during the COVID pandemic, that is the education, the training to the personnel, because if we have rapid tests and we have no prescribers alert to looking at the computer, the WhatsApp groups where we rapidly advise with the result of this PCR, the NDM, KPC, or the SBL or lack of test, of course, there will not be difference between the rapid tests and conventional tests that are 2 or 3 days waiting for a resistance. That's okay. Perfect. Diagnostic stewardship without education, training, and groups, WhatsApp groups, and other form of alert, the prescriber, intensive care units will be useless. So this is important because in Argentina, in Latin America, we had the issues in the pandemic, of course. We have the control of antimicrobial. The first problem in Latin America in general, we didn't have that problem in my hospital, is that all the stewardship team, the just beginning, the very germ of the stewardship teams were devoted to different tasks and not to the stewardship. Stewardship was neglected during pandemic. That was a stupid thing all over the world and in Latin America in particular. So when we try to recover with the countries that things, of course, antibiotics or antimicrobials were controlled. Of course, the resistance rise, the cost rise, the consumption rise, because of another point that was the lack of prevention and control infection. So you have a control of antibiotics, but you don't have prevention and control infection because it's less personnel, ill personnel, exhausted personnel, the overwhelming number of patients in the ICUs. Of course, people that don't adhere to the hand washing and the care of the central vein lines or the respiratory secretion, etc. So more infections, more antibiotics, more resistance, despite all the stewardship teamwork. By the way, in lower middle income countries, I don't know, I don't need to clarify this, but just in case to India or the other part of the world, stewardship teams are always 2-3 people trying to teach or to share the information as crazy people all over the hospital. And this is a problem also in these issues. Briefly, a whole view of the problem. Thank you very much.
Yes, Gabriel, you made the right statement. During COVID, we neglected antimicrobial stewardship because we were saving patients, and during that process, probably we killed some patients as well. I could see Pierre raised his hands. Pierre, are you still there? Because we can't see your face, but we can see, oh, you're still there. Sorry, I thought you were disappeared, gone for coffee. That's why I didn't ask any questions to you. I'm so sorry about it.
No problem. But as my connection is not good, I switch off the video when I'm not talking because it gives the connection better. So I can follow all what you're saying and the other experts are talking, and it's very fascinating talk. Thank you. Now, I had just one comment about the rapid diagnostic test. There was one that was quite good, and it helped us to reduce the use of unnecessary antibiotics in France, was the group A strep in people with pharyngitis, because it's a rapid test. And what the GP told us is that when they say to the patient coming at their consultation for pharyngitis that they don't need antibiotics, often patients were thinking they were not taken seriously. But if the doctor do the test, which will be most of the time negative, it's maybe less than 20% of pharyngitis in adults that is related to group A strep, then the patient would feel that he has been listened and he has been taken seriously. So they would accept the fact that they are not prescribed antibiotics because they saw the doctor testing what they have in the throat before deciding they won't receive antibiotics. And if I may allow one comment about AMR and COVID, I think it was really illustrative of how strong the antimicrobial stewardship was in the different countries when the COVID came. Because there are some countries, maybe like Argentina, where it was the early days of antimicrobial stewardship in many hospitals, so they could not really impact to have better use of antibiotics. But you have other countries where the consumption of antibiotics decreased a lot because they had good antimicrobial stewardship before the COVID. So the people were trained and could easily follow the rules that were not give antibiotics if patient has just COVID. And I know many countries like Canada, and it was the case in France, but less, decreased the consumption by 20-25% during 2020, because first, the people get less infection because of better infection control and also because of lockdown. And second, how to say that, the patient, they were informed that they should go to the doctor, to the hospital, only if they have very severe disease. So there are many people who did not go to the doctor during that time because they thought it was not serious enough, so they were not prescribed antibiotics, and they just get cured by themselves spontaneously. So thank you for the organization of this talk. Very good.
Thank you, Pierre. Yamuna?
Yeah, sir. Thank you. The point which I wanted to stress is, as I practice infection prevention and control, same quoting the example of COVID, actually the rapid test helped us to allocate resources for the COVID patients. The moment we come to know that person is COVID positive or COVID negative, the resource allocation was very easy, like shifting the patient to a COVID care center and keeping them in the non-COVID care center. So that by diagnostic stewardship also helps out in infection control practices, not only in the treatment stewardship. That point I just wanted to make it very strong that the stewardship at whatever level is being done, ultimately it helps out in infection control practices also, and that's how it helped us during the COVID season. And when in the last third phase of COVID, or the third wave of COVID, when India faced, where we started to see more of other respiratory illness over COVID. So again, there was a confusion where to keep this COVID patient as compared to other respiratory illness. We didn't want to mix this patient, and definitely rapid diagnostic tests helped us in this resource allocation.
Yeah. Perfect statement, because today we see more number of flu, RSV, and rhino than COVID. And Arvind, your experience on this COVID issue?
COVID issue, I agree with all other speakers and their opinions. In 2020, because the IPC at the community level, because of the other non-pharmacological interventions, lockdowns, etc. In Kerala, the azithromycin and antibiotic consumption was 30% less compared to 2019. But then the community level IPC is not that sustainable. So by 2022 and after the middle of 2021, the antibiotic consumption started increasing, like in the rest of India. So the importance of the community level IPC was demonstrated to a great extent during the first phase of the COVID pandemic, where all the other respiratory infection incidence was pretty low. And so the antibiotic consumption was less. But once the IPC took a hit because of practical reasons, all of the respiratory infections started coming back and antibiotic consumption started increasing at the ground level. And I believe that in 2022 and 2021, the total sale of azithromycin in India was more than 1,000 crore, which overtook the sale of the insulin, etc. So in that respect, the second part of the COVID in India, so it was a huge disaster as far as antibiotic stewardship was concerned. And it also highlighted the fact that antibiotic stewardship has to go hand in hand with diagnostic stewardship and infection control. So the onus in India has to be on infection control. If you can prevent infections, you can definitely prevent the use of antibiotics. And diagnostic stewardship, that is, as I highlighted during my first answer to first question. So it was the only time where all the government sector had access to this molecular diagnosis. So we were flying blind prior to this COVID. And after COVID, the molecular diagnosis, for example, in Kerala, we had 134 molecular diagnostic centers for diagnosing COVID in the government sector itself. So we knew the diagnosis so that we could, stop the use of antibiotics, since we know it is COVID like that. So I believe that COVID taught us that infection control, antibiotic stewardship, and diagnostic stewardship has to go hand in hand.
Yeah, perfect. OC, in your absence, we discussed 3 topics. One was access, and number 2, the COVID and AMR, and number 3, the diagnostic stewardship. The access, COVID, AMR, we could not see much enthusiasm among panelists because we have discussed this 100 times before. But diagnostic stewardship, I could see some real enthusiasm among panelists. What is your opinion about the diagnostic stewardship in India? Mic is off, OC. Your mic is off.
Yeah. Can you hear me now?
Yes.
Yeah. See, first is I would like to clarify the term diagnostic stewardship. I think all the speakers, what they have in mind is improving diagnostics to aid antimicrobial stewardship. Like all speakers said, appropriateness of antibiotic therapy depends on making an accurate diagnosis. And an accurate diagnosis starts by making a diagnosis, either syndromic or a very specific diagnosis like a community-acquired pneumonia or an acute undifferentiated febrile illness or whatever at the bedside, then ordering tests appropriately, interpreting the results, and this leading to appropriate antibiotic therapy, starting, stopping, de-escalating, changing, etc. Studies have shown 2 from Mayo Clinic, 1 from UK, primarily with blood culture reports, BCID panel, which makes both identification and antimicrobial test results rapidly available, does not lead to change or improved antibiotic therapy. Only when it was added on with appropriate AMSP interventions. A team of specialists of antimicrobial stewardship specialists gave advice on changing antibiotic therapy appropriately, an appropriate change occurred. So making tests available just leads to overutilization, and we know that when the pretest probability is low, a false positive result is a positive test result is a false positive. We know example of beta-D-glucan in candidemia. Unless the pretest probability is high, it does not make a difference. So rapid diagnostic test, making it available, yes, we should do that, but it should be combined with appropriate AMSP interventions. Otherwise, you have the test available, it's not communicated to the clinician. Clinician doesn't know when communicated what to do with the result. There should be an input from a specialist team.
Also, you mentioned about antibiotic stewardship, diagnostic stewardship, infection control. If you really want to invest in any one of these, of course, we have to invest in all the three. Which one could be the most cost effective in an Indian setup?
Improving diagnostics, making rapid diagnostic tests, which make a difference in the patient management and thereby patient outcome. So we need better tests to improve management and make a difference in patient outcome. Like Arvind said in the beginning, even after the practitioners knew it was COVID, they still went ahead and prescribed antibiotics. There was no difference. So it has to be combined with IEC activities, clinician education. Yes.
Because you mentioned that, so we have to, the best one to invest is diagnostic stewardship. Is that because we have been talking about AMS for a long time, IC for a long time, and now we have to invest on diagnostic stewardship?
Like I said in the beginning, the reason for inappropriate antibiotic therapy is an inaccurate diagnosis. And a lot of people say inaccurate diagnosis because we don't have access to good laboratory tests, diagnostic tests. But I see that in my day-to-day practice, we don't even make a good diagnosis at the bedside. Okay. One classical example is you said about urinary tract infections. We know that substantial number of positive urine cultures indicate only asymptomatic bacteriuria and not true urinary tract infection. So you have to diagnose a UTI clinically, then order. So if you have a rapid test, a drop of urine, it tells you that it's E. coli, it's Cephalosporin, third generation cephalosporin resistance. I have my diagnosis immediately. But you have to make the diagnosis of UTI clinically. Elderly lady, little confused, has an indwelling polycatheter. I send a urine sample. Of course, it's going to show a bug. So, that gap of that clinicians keeping on saying that I do not have access to accurate, reliable lab tests. Therefore, I treat empirically. At least that part can be handled by this availability of rapid diagnostic tests.
Sunita, you are a member of your state AMR committee, and Sunita, which one you will recommend to your state government? Diagnostic stewardship, antibiotic stewardship, infection control, of course, all the three. But which one you stress upon?
Like Dr. Rossi has told, you cannot do antimicrobial stewardship without diagnostics. So that will be the first place to start. You need better diagnostic facilities, you need lab facilities, and the ability to interpret the reports appropriately. So my first choice would be diagnostic stewardship. Of course, that goes hand in hand with infection control. So you can't, infection control is definite. Between diagnostic and antimicrobial, first one will be diagnostic.
Priscilla, we are discussing about the investment in infection control, antibiotic stewardship, diagnostic stewardship. Which one you will invest more? No, your sound. No, we can't hear you.
I guess there's nothing like only one arm is important. All the three arms have to work in tandem for us to be able to achieve actually a reduction in our antimicrobial use. But if I were to invest in something, I think what is likely to make a major change will be a diagnostic stewardship. So I would start with that and then go on to, of course, infection control and then antimicrobial stewardship. So as long as we're able to diagnose something appropriately, we should be able to rationalize the use of antibiotics prudently.
Yeah. Gabriel, first of all, do I have any conflict of interest in diagnostic stewardship? I'm keeping on stressing diagnostic stewardship.
Excellent question. It was very tricky when I read this, and I will be voting, I will be swimming against the stream because I will go for antimicrobial stewardship. Why? Because antimicrobial stewardship, is trying to engage the three components. Why? because IPC without antimicrobial stewardship and without diagnostic, it's like staying always in the same place. And that was happening usually in, for example, Latin America. We have advanced IPC programs, infection control programs, but no more than that. Antimicrobials are still bad use or misuse, and diagnostic stewardship so-so. If you go only for diagnostic stewardship, as my friends and partners are voting, we have no education probably, as happens, and I mentioned previously, diagnostic stewardship without education to get used to the rapid test or the selection of the antibiogram interpretation, etc., is only usually. Then I will definitely go for AMS because we can begin with teaching, we can begin using better the antibiotics, we can push the diagnostic stewardship as heads of antimicrobial stewardship. We have their director of the hospital. We should have to go these 2 or 3 tools for diagnostic, for rapid diagnostic tests to use better antimicrobials and other things we have talking. And then also in diagnostic stewardship, in antimicrobial stewardship, you are recognizing that we are lacking of diagnostic tests and we are lacking of IPC, as I told. We did the best as we can antimicrobial stewardship in the peaks of the pandemic, antimicrobial stewardship, yes, but then we realized that the leg that was lacking was the IPC, the infection control prevention. So how we can do antimicrobial stewardship with a low IPC. So are all linked. Hope you understand my vote about for stewardship, antimicrobial stewardship.
Good. That's a different sort. That's an interesting viewpoint. I can see Pierre raising hands. Pierre?
Yes, thank you. My opinion is that it is very country specific, and there are some countries, I could take the example of some countries in Africa, low and middle income countries, that probably IPC would be the first step to go, because there have been some audits that show that any inpatient would have a venous line that will be put in place as soon as they arrive in the hospital. And most of them will get infected after a while because they will also sometimes have the urinary catheter as well. And probably just infection control, such as don't put lines when the patient don't need it, or don't put urinary catheter when the patient don't need it, will probably decrease a lot the use of antibiotics, because it will decrease the nosocomial infection. And that it would be maybe the first step in some places. And in countries like my country in France, for sure, the first, I agree with Gabriel, we need to improve on antimicrobial stewardship and to put the money there at first time, because that's the place where we need the most.
Very interesting perspective. This is the advantage of having experts from across the world. We got a different opinion. In low-income countries, probably we have to invest more on IPC. In high-income countries, antimicrobial stewardship. And middle-income countries like India, OC, but with the balanced change.
I will echo what Priscilla said. All are 3 pillars. So the 3 strong pillars, AMSP, IPC, and improving diagnostics for improving antibiotic usage, meaning all are 3 pillars. If one pillar is gone, you will fall down. So you cannot, I don't think you can make an argument that one is more important than the other. But then as the scenario is in India today, people quote that I don't have an accurate diagnosis in terms of the microbial etiology and the antibiotic susceptibility pattern. Therefore, I treat with combination of very broad spectrum antibiotic therapy. At least that excuse can be made invalid if you have access to accurate, reliable, fast test with the rapid turnaround time. So I agree that all of the 3 are 3 important pillars, and one pillar is gone, the base is unstable. So you cannot separate, but which one will you invest in at the moment? That's the question. I will vote for improving diagnostic testing.
Diagnostic stewardship. Yeah, Heyman, would you please raise that placard again? You raised a minute, 2 minutes earlier. I missed it. I saw you
So,
raising something.
I go for diagnostics. So
Yeah, but
of
can
course,
you show that
everything-
placard again? Let the audience see that placard. We missed it. Yeah, see, I saw something. I forgot about it. I go for diagnostic stewardship.
No, just for so I mean, your surveillance depends on diagnostics. So no diagnostics is like sailing a ship without a compass or driving in the dark without your lights on. I mean, you need it for both. So I think it's really the pillar. In the Netherlands, clinical microbiology is quite strong, and actually, everything was sort of infection control is informed by it, and it's well developed, because also for there you need, okay, what is actually causing hospital-acquired infections? What can we do about it? And the same for stewardship. And now, particularly with the newer antibiotics, carbapenem resistance, people start to use ceftriaxone, avibactam, all kinds of things. People think, okay, I can use this for carbapenem resistance, but you cannot. You have to know what is the resistance mechanisms behind carbapenem resistance. Otherwise, all these new compounds, they don't make sense at all. You waste a lot of money. So diagnosis is key, also for your stewardship, and not the other way around. Over. And infection control.
Yes. Now the audience, we have got participants from around the world, attendees from around the world. And can you see the change in perspective in the discussion? We are moving more towards diagnostic stewardship. Yes, still in low-income countries, IPC ranks the most. In middle-income countries, all the three components with additional stress on diagnostic stewardship, and in high-income countries, diagnostic stewardship. That's a nice idea that's emerging. Yamuna, what's your opinion on this? It's become a very interesting topic.
My opinion is even all of us come from a place which has a very good diagnostic. We also have a backup team, who talks more about the treatment guidelines to people. But many places we have seen even inside the ICU, if patient A has Acinetobacter multidrug resistant organism or carbapenem resistant, the moment patient B has a fever, the clinician's thought process is, I know this is going to be Acinetobacter. Why should I even wait for the diagnostic? I know it's Acineto. There was a breach in infection control practice, so I will start polymyxin for this patient. So I believe the roadmap is definitely towards prevention and control. Of course, diagnostic stewardship is needed in a place, but still I believe that without infection prevention and control, bringing in stewardship is not going to stand the way.
You're right, because even I don't need a rapid diagnostic. The background slide, your background, I'm sure is Klebsiella. I don't need a rapid diagnostic. Is that a Klebsiella?
That's a Burkholderia, sir.
Oh, fine. So this is what people believe. It was a Burkholderia, and I'm sure it's a Klebsiella, and entirely different. That's the problem with clinicians. We know that we always believe we know, but it's not right. That's importance of diagnostic stewardship. Raksha, your opinion.
So yes, just agreeing with everybody that the three pillars that Dr. Rosie Abrahams has said, antibiotic stewardship and diagnostic stewardship and infection control stewardship. Again, it's region and institution specific. You do a root cause analysis and you identify the low hanging fruit in your institution. More so in many institutions, the focus would be on infection control. Thanks to the COVID pandemic, what we spoke about. Many of us now know what are the 7 steps of hand wash and why WHO recommends this and why are we doing it, how to do it, the steps. Everybody has some amount of clarity regarding this. And again, antimicrobial stewardship is something, everybody's speaking about. There's a lot of continued learning happening. And diagnostic stewardship is something which is a domain which is not focused on that much. So agreeing with all the panelists, I think we as ID specialists and infection control specialists, diagnostic stewardship is one area where we can focus our resources on, and also see to it that whatever is taught and learned gets translated to practice. There's a lot of awareness, but then is this awareness translated to behavior changes? So that is something which we should focus on and see whether whatever we are teaching and what we are implementing in our institution, is this translated into prescription practice changes? Is it reflecting on our antibiotic choices? And all those things have to be really focused on. And diagnostic stewardship is something which is we have to work on. And my choice would be diagnostic stewardship.
Vasant, you are our deputy managing trustee of the AMR Trust. We can observe an interesting point. our trust, we have been conducting so many meetings and we never conducted a session on diagnostic stewardship. And now we realize that, the topic of the time is diagnostic stewardship. What do you think? What should we do now?
Absolutely, sir. I think diagnostic stewardship is the way to go forward, because that is the lead to, antimicrobial stewardship, using appropriate antibiotics, reducing the cost and reducing the hospital stay, as I given the example. I think if you have good diagnostics, good, correct, and you may not use antimicrobial. Meaning, if you can diagnose as a proper viral infection, you may not use the antimicrobial therapy at all. So I think the way forward is to have, I think, diagnostic stewardship and the infection control. I think we should have our next seminar focused on these 2 points in depth. So.
Thank you, Vasant. I think we have to move from this topic. Otherwise, it looks like a very, very hot topic. I will move to the next topic. That's to our, APUA ISAC members. Pierre, and would you please update us on the planned APUA ISAC guideline on directed therapy?
I can, but I think Ayman would be better than me to do that because he was leading the project. So maybe I see he's here. Maybe Ayman.
Oh, wonderful. Yes, Ayman is here. Ayman, you can answer the question.
Yeah, so we have so thanks for asking. So WHO has developed the AWARE handbook. So that's more for empiric treatment for common infectious diseases. But there's actually nothing for directed therapies. And so if you know the bug, so one, and you know the resistance mechanism, it has consequence for the choice of the antibiotic. So what I just mentioned about the carbapenem resistance is important to know the mechanism. So we also, for the different mechanisms, we can also, for carbapenem resistance, we can show, okay, these are the different antibiotics that you need to choose for your patient. So it's really also to show also the importance of actually accurate diagnostics and how that impacts your use. So direct therapies really depend on diagnostics. So it actually works both ways. People get better treatments. And 2, it also shows the importance of diagnostics to guide treatment. So we're actually quite busy now. So it's going to be app-based, so people can use it open access worldwide. So there's no cost involved. And so actually now we have varied chapters on different diseases of bacteremia, meningitis, respiratory infections. Urinary tract infections have been developed, have been peer reviewed. And now we're building and populating the app. And then hopefully somewhere next year we can launch it. But we only want to launch it once we're really confident, it's really good to go. So it's a reliable source for everybody across the world. But you're running all kinds of different issues because there's so many different antibiotics. So for quinolones, if you choose a quinolone, you use Cipro or Levo or no. So which one do you choose? The most common one. So there's so many issues that we're trying to solve to come to a proper consensus. So also the peer review in this process is really helpful. So it's a nice project, and we look forward also, if people are interested, to peer review, let me know, and happy to put you in. Thank you. Over.
Thank you, Heyman, for the trailer on the APUA ISAC guideline. Pierre, what do you think? What impact the ISAC APUA guideline targeted therapy will make at the global level?
Yeah, I wanted to add 2 important things, and Ayman, you can correct me if I'm wrong, but one of the important things is that the funding is totally non-related to industry, to pharmaceutical industry, so that we are sure that we will have no any kind of influence on what we will suggest for each bug. And the second point that is important, as it is planned to be used worldwide, it will be somewhat adaptable so that you can change a little bit what is recommended according to the profile of your bacteria in your country, but also the antibiotics that are available. So we hope that we will contribute to a better use of antibiotics. And Ayman did it very well with Suha Kanj from Lebanon. They both co-leaded the project, and it's something that will really, I think, reflect what APUA is wanted to do, is to improve the prudent use of antimicrobials worldwide.
Yeah, thanks, Pierre. Nice to hear the Soha's name. And for the audience, even though we have 3 male members from APUA here, including me 4, we have got several leading female members in the APUA, and unfortunately all of them were on vacation, isn't it, Pierre? they couldn't join us.
Exactly. We invited 5 and they all said they would be very interested to participate, but they all were in vacation this week.
August, the problem of having a meeting in August, that's we understand. Gabriel, your opinion on our highly anticipated APUA ISAC guidelines.
Yeah, to complement the thing, this is very dialectic, no? We were discussing diagnostic stewardship. I was voting for the stewardship because all is a relationship with education and training. If we have guidelines, as well as we have diagnostic without proper treatment guidelines that are disseminated, that are really discussed with the people that are accompanied by training of the people, discussion of the guidelines. Guidelines are very important, but we know that guidelines are probably resting in the computer or in the secretary of the boss. So will be a great tool, as many other guidelines are, but we might accompany it with showing them with real day-to-day education programs, not only by APUA or ISAC or the governments, but our work in the hospital is very important to disseminate that guidelines, because if not, guidelines are useless. This is a great problem with CPCs. The other thing that's very important, that as Pierre mentioned in this case, that they are not sponsored by any industry, any pharma, because we know that many guidelines from different countries, you have some smell of this has some hidden sponsorship, and regarding the choice of drugs, etc. So this will be very clean guidelines, and we'll have to disseminate them to train people and to discuss every day the guidelines with our prescribers.
It's very interesting. ISAC APUA guideline absolutely not funded by the pharmaceutical industry. So we can expect a very, very unbiased guideline. Now again, and Arvind, coming to for example, if you get any guideline, whether it's ISAC APUA guideline, at the grassroots level, what could be the challenge in implementing any guideline at grassroots level?
Actually, Kerala is one example where we have the state infection control policy and antibiotic policy guidelines. But then majority of the doctors at the ground level are not aware of these guidelines. So that is the basic problem. So, and that is the reason why, after say 5 years of a strategic action plan, we decided that, we need to have decentralize our AMR action plan. So we created the district level AMR committees in all the 14 districts, the block level AMR committee, so that we are actually going out to the doctors as well as to the public. So, otherwise, the majority are not really aware of the national guidelines. India has 2 national guidelines, one ICMR guidelines and CDC, and no one is aware of any of this, the guidelines. And we have the guidelines in app form as well. It's actually very difficult to engage with the current group of the residents also. They also are not really aware of all this, the treatment guidelines and all. So a multi-pronged approach is really necessary. We need to use social media. We need to have the print form, the technology, everything has to be used to drive home the fact that standard treatment guidelines, etc. are there, and that has to be followed. And one good advantage is this WHO aware classification, which makes it very easy for us to monitor, at least in the PHC level, the primary health center level. We clearly know that only for all the infectious syndromes which are likely to come to a primary care physician, either no antibiotics are required or only the access group of antibiotics are required. So at the state level itself, we have taken a foreign restriction sort of thing, that only the access group of antibiotics will be given to the PHC doctors. It is to ensure that more than 95% of the prescription at the primary care should be from the access category. That doesn't mean that this access should be prescribed. That is the first step. The second step will be to educate them that even this access category may not be required for majority of the respiratory infections. So it's a very difficult task actually.
Yeah, very interesting. In Kerala, you're doing an excellent work. It's nice to know that. Priscilla, again, the question again, grassroots implementation, and that's the niche and the crux, I would say, crux in implementation of AMR policy. How can we make that change at the grassroots level?
So I think not every state is like Kerala, where I think action plans have filtered down right to the district level and then to the primary care level. So it's often quite challenging to be able to initiate interventions which require different approaches for different healthcare settings. So while I totally agree, we need, an approach like, for example, I think that what Arvind talked about, the access group of antibiotics being made available for the primary care setting, and then probably going up to watch to the district, and then, having everything available for the tertiary care setting. Unfortunately, I think we actually did do a study in the secondary care where we, implemented a standard package at secondary care level. What we did find was there was definitely carbapenem resistance and ESBL. Of course, it was nowhere near what we see in the tertiary cares. It was, CRE was probably around 3 to 5%, and, ESBLs were anywhere from 20 to 40%, depending on which part of the country it was for. So having said that, it's very difficult to kind of implement a one-size-all approach. I think we need data from these settings. And unfortunately, in our country, our surveillance in primary and secondary care is lacking. I think that is our biggest challenge. So to be able to tailor-make interventions that will suit those settings is often, we are never going to have, it's always going to be flawed till we actually have data. But I think we have to start somewhere. So starting somewhere with, simple surveillance techniques, just giving them access drugs and then seeing what happens, I think is a good strategy as well. But I think we need data. We need surveillance data before we are able to kind of implement interventions at each of these healthcare settings.
Yeah. OC, now, other panelists mentioned, we can have any number of guidelines, but people are not aware of the presence of guidelines, and medical students are not aware of any of the guidelines. And how can we make that change from our youngsters?
Yeah. A multi-pronged approach. Number one, if you're making guidelines, it should be based on, you should follow all the guidelines to make a guideline, or otherwise it should be a consensus document or an expert opinion only, and we should only call it only that. That itself will improve the credibility of whatever guideline or expert statement or consensus document you're putting on. Second is, like Arvind mentioned, Priscilla mentioned, dissemination. Having a guideline is important, and it should be dissemination. Dissemination should start during their undergraduate medical training, during their pharmacology classes, during their rotation in medicine, other specialties, infectious diseases, during their internship and their residency, and all the CMEs and continuing professional development activities, etc. And this should be done by on an evangelistic zeal. And at the moment, it's very passive. Although guidelines are there, people are not aware of it. Even if they are aware of it, they don't want to use it because they don't think it's appropriate for their setting. The next point I want to make is that when you make guidelines for antibiotic usage, extremely important to have guidelines for empiric usage and directed treatment. And I would emphasize empiric usage. Like Arvind said, I want to echo Arvind again. At the primary level, a substantial number of the infectious syndromes we see, respiratory infections, diarrheal illnesses, AUFIs, we don't need an antibiotic. So that message itself would go through. So make the guideline or expert statement or consensus statement, disseminate it starting at undergraduate medical education level, update it, and very important to have both empiric and directed treatment guidelines for both, and educating the practitioner that a substantial number empiric, the infectious syndrome, we may not need an antibiotic at all, like that.
Yes. Raksha? We can't hear you.
Muted, you're muted.
Yes.
Yeah. So to add to what Dr. Roshan,
We can't hear you. Something wrong with the voice.
yeah,
I think it's
Can you
poor
hear me,
connectivity. Poor connectivity, I think.
you
Poor
can hear me,
connectivity.
sir? Can you hear
Yeah.
me, sir, now?
Yeah,
Yes.
better.
Yeah, so to add to what Sir said, we are looking at bringing the
Raksha, we'll come back to you. We'll come back to you. There's some poor connectivity. I'll come back. I'll go to Heyman and then come back to you. Heyman?
Yeah, I'm just going to say how it worked in the Netherlands. Also here we had poor compliance to guidelines. And actually so we have the professional societies are quite key in compliance to guidelines. So we do audits with everybody, every institute where there's a department of surgery or department of micro, department of infectious disease. We visit each other every 4 years or so. And your peers check, are you doing everything according to the standards of our profession? So that's one. And also some key guidelines regarding infection control. Also the Dutch inspectorate, so the government checks whether you are compliant with the guidelines. So there are two ways, and if you don't, you have to show actions that you're improving, and they will visit you again in a year or so. And if it's really a severe deviation of the guideline, you have to really solve it very soon. So it's also about patient safety, and the government is quite strict in actually seeing if people are really adhering to the guidelines. So also foreign eyes looking with you from another institute or the government does help as well.
Yeah, thanks, Heyman. Pierre is still there?
Yes, I am.
Yeah, we just heard, we need a guideline. Probably should we have a section on how to implement the ISAC APUA guideline? Because we now learned that having a guideline alone is not enough. The implementation is the key.
Yeah, of course. And I think what Hyman just said is very efficient at a national level to try to involve the scientific societies that will use the guidelines before publishing the guidelines. And second, to have something officially in charge of checking that people are complying with guidelines. But both would not work for such a world guidelines because we cannot be checking what the people are doing. So we will try to communicate a lot through different ways to try to get the feedback from people so that they can tell us what is useful in their implementation of guidelines and what has to be improved. And we will also try to revigorate the national representative of APUA that were called chapters a few years ago. And that was a good way to have like a national board from APUA that will be able to check that the implementation of guidelines is properly done in each country. But I don't think we have other way to do that because the world is too big and we have no authority on what is done with antibiotic use worldwide.
Yes, yes, world is too big and AMR is too complex. Right. Gabriel?
Yeah, just a couple of things to stress. When I began and I chased the point saying that without dissemination, the guidelines are absolutely nothing, are probably for the egos of those that write the guidelines and are publishing the guidelines, but no more than that. For example, and taking with OC said, that is very interesting. For example, we have worked with the WHO in 2019. We have built a health workers education and training on antimicrobial resistance. What is a great curriculum guide of what should we learn, what should we teach, what might be included in the curriculum in pre-graduate, in the schools of medicine, pharmaceutical, etc. Obviously, I think that less than 5% of us are aware of this, and we are not applying these things. We are making tools that are further not disseminated. And that is a big problem. That's what I'm voting for: stewardship, antimicrobial stewardship, and local champions to try to disseminate that guidelines. And the education might be in the day-to-day basis. Education may be the incidental education, the work rounds with prescribers, the implication prescribers to read the guidelines, to discuss the guidelines, patient by patient. Only distant learning curves, for example, without the day-to-day enforcement of the knowledge is really it's not the same as working. And regarding the APUA, we were thinking in the last meeting that we miss you really, Abdul, because different issues we missed you. That would be great to involve not only the chapters but also, as we began with the antimicrobial stewardship working group in the ISAC, where many representatives for many countries were working with us, and that will be like multiplicating all these things, the work in the ground, the dissemination of guidelines, the education, and other things we are discussing. Just to complement what Pierre has just said. That's my opinion.
Raksha?
Am I audible, sir, now?
Yes.
Yeah. So just to add to the discussion, we are talking about education and training regarding antimicrobial stewardship. One newer concept that I have been working on as a part of my fellowship is an interprofessional approach to antimicrobial stewardship. Now, this is an educative component where we are looking at antimicrobial stewardship in a very siloed approach. What's happening is doctors know about antimicrobial stewardship with an antibiotic prescription background, diagnostics. So a staff nurse will be looking at infection control. A focus will be more on that. And probably the administrators are looking at the hospital bed turnover. So if all of you are aware of the famous fable of an elephant and 6 blind men, it's something like that. So everybody has their own interest with regards to AMSP. So when you teach in AMSP with the interprofessional approach, get everybody in a room together instead of teaching nurses separately in a classroom or doctors separately in a classroom. Give them a real life scenario. Use newer approaches of teaching like simulation or say a case-based learning, a problem-based learning. So the module of training these undergraduates has to be a little different, very similar to what is actually happening in a hospital setting. So if you actually look at the Indian scenario, very recently, AMSP was made mandatory as per the National Medical Council. AMSP curriculum has to be in the undergraduate training. And if I'm aware, even AMR Declaration Trust has published a freely available book for undergraduate students, which I think many of them are actually looking into it, and it's in a very simplified language. So we need to get down to that level and teach the students.
Yes, Raksha, we learned that, our AMR Trust handbook on AMR, AMSP, and IC for undergraduate students, very, very popular. Many universities have decided to introduce it for their students. Vasant?
Yeah, I think I just wanted to second both what Dr. Shaz said about having antimicrobial stewardship and antimicrobial resistance to be included in the medical school right from undergraduate, and a compulsory not only for postgraduate medicine students but for every faculty, whether it's a surgery, gynec, optal. I think it's a must unless this subject has to be compulsorily made. Only then people will understand when they come out into the clinical practice what is an AMS and what is antimicrobial resistance. And also similar to interprofessional relationship, just having an antibiotic policy rolled out in the hospital by the infection control team and the by the microbiology team does not suffice. People don't follow that. It is just like an guideline made. People will not follow that. So you have to take interprofessional. What we have been doing in earlier when I was in Global and now at HM Reliance, what I've been doing is that whenever I have to form an antibiotic policy, say for a urosepsis, I get the nephrologist, urologist in the room. I have a discussion with them, discuss with them what do they know about the resistance pattern in the community hospital, and to have a jointly discuss with them ki this is our resistance pattern or microbiologist displays. And then we discuss what would be the right choice of antibiotics. So then this is properly followed. Similarly, we have a discussion with the orthopedics and other teams also. Similarly, even for surgical site prophylaxis, we have this discussion with individual faculty, individual departments. Like only then it is followed. If you just roll out a program and tell them that you have to follow this, or this is just for the, for the JCI accreditation or ABA. That is not enough. You have to get them into confidence, take them into a part of your system. Only then it works better. That is what we have been doing it, and we're finding it to be quite useful.
We need to convince all the stakeholders, not just for accreditation. It's really saving lives, and it's very important. Yamuna,
Yeah, I'm there, sir.
yeah, what do you think? Vasant made a statement. How can we convince people? It's really that is something important and not just for accreditation.
Yeah, sir. I would go with all the panelists. They have elaborated all the points, just putting together everything in 4 E's. It is about engaging people, educating them, then empowering them, and then enforcing them. We can't start with enforcing, so we need to engage each and every stakeholders in whichever part they are or they belong to, then educate them, then of course empower them to do that, and then enforce the practice whatever is happening. I mean, that puts all the points together which was mentioned by each and every panelist. And as Dr. Arvind mentioned, that we need to decentralize the program. We can't hold the program at one level and make sure that everyone at the grassroots level are following it. So we need to decentralize it, involve more people in the program, so that we have an appropriate surveillance system. Just by disseminating the guidelines is also not going to help us, but we need to have a consistent follow-up, which is what we call it as surveillance, whether those things are in place, whether it's been followed or not, or who is not following it, or who still has a lack of knowledge and awareness about it, is what I feel is important.
That's a very good summary of the complexity of AMR. And Heyman, do you remember when we started discussions about this joint meeting, I suggested we are going to have a webinar on AMR, and Heyman answered me back, yeah, but which aspect of AMR? I replied back again, the AMR. I understood Heyman's question, because AMR is like a specialty. It's like discussing cardiology, neurology, infectious disease. Still, we decided to conduct the meeting on AMR and not any particular aspect of the AMR. The reason is we have attendees from across the world. We have more than 700 registrations from around the world, and we want to convey the message again and again. How complex AMR is, how intricately linked various components of the AMR is, and how AMR, though a complex challenge, how the various components differ in different parts of the world. Gabriel, how complex AMR is, and how can we reduce the complexity?
Well,
You have to unmute.
Before one thing, can I share these things, what I wanted to show, just because we have many. Let me know if you are looking. Can you see this?
Yes.
Well, this is the guideline that we work with Dr. Onyema and the team in WHO, where all the things we might teach or might include in our preschool, in our schools of pregraduate fields for different medicines, pharmacies, nutritional, nurses are here. So as you said, that many people is probably here looking at this or will look at the record later, will be interesting to take a look at this, so we can share the things we were doing, and probably we can begin to discuss how to learn, how to teach in the earlier stage. So thanks for this. Now, to be simple, again, the question was, which are the difference, the grounds of antimicrobial resistance? Can you make another question, because I was thinking in that, Abdul, again, the question.
How complex the AMR is across the world?
It's very complex. It was a short answer. It's very complex. We have, as you said, these different issues in different countries. In many countries now in Latin America, the great problem are the growing of carbapenemase resistance over different enzymes, different mechanisms of resistance. So we cannot face them all together. This is related to the lack of stewardship, the lack of diagnostic, the lack of IPC measures. And in the community, we also have the problem, but the problem in the community is more related again with education, with the OTC counter, sales of medicines, different access. But I think again that, I'm sorry that I insist with the training and education, this is a matter of education. Probably in the question you said, for the next time we can think that, because education and training is across all the things we are discussing, when you made us vote, that was very really interesting discussion between where do we need, where the governments needs to put the money in IPC, in IMS, or in stewardship. I would vote also education, because education, legislation, fiscalization, because the over-the-counter sales in community, in primary care, is also related with education and with the lack of the decisions of the governments to really address that point and to really avoid the sales. So I try to put it all together. I don't know if it's clear. Thank you.
Heyman?
Yeah, thanks. So it is complex, but let's not get lost in the complexity and just set like very clear targets. So prioritize and set a target. We want to reduce DDT in this antibiotic, and then have clever people come together and think about how are we going to achieve it, rather than sort of sometimes I have the feeling we're being stuck. Oh, it's too complex, and it sort of leads to inaction. Just also start and keep on learning and keep on setting the targets to the next level.
Good, Heyman. Let's demystify the complexity. Let's not lost in the forest. Pierre?
Yeah, I was about to say almost the same. The problem is complex, but the solution is not so difficult. And it has been proven in many ways, in many places in the world, that if you improve the proper use of antibiotics and infection control, within a short time, you will see a decrease in AMR. So it's just to say the same as Heyman is, problem is complex, but solution is not so difficult to identify.
Yeah, it's nice to hear, a positive attitude towards AMR, the solution of AMR. And now let's discuss about a very complex aspect of AMR, and that is the AMR problem in agriculture and environment, the veterinary antibiotic usage, the agricultural antibiotic usage. Sunita, now considering the complexity, should we think about how this particular aspect is different in various countries, how this issue is different in developed world and the developing world?
This is a very complicated topic, like how you mentioned. Antibiotics are used as growth promoters in multiple all over the world, for that matter. The kind of antibiotics that are used are probably slightly different. For example, if you talk about antifungals, we see voriconazole resistant aspergillus more in Europe as compared to other places. That's just an example. So the kind of antimicrobials used, I would say antimicrobials here, when you're talking about agriculture use, is different in various parts of the world. But the bottom line is in almost unanimously antibiotics are used. Now there is some trend in some small pockets where the organic farming is coming up which will help, but that's very, very tiny percentage of agriculture. For the most part, antibiotics are abused both in agriculture as well as animal husbandry, both. In India, I think thanks to some of the initiatives of the Chennai Declaration and thereafter, we have, of course, banned colistin from agriculture use. But I think we have a long way to go in terms of decreasing the antimicrobial usage there.
Yeah, yes, Sunita, you rightly said. We could get the colistin banned as a growth promotional usage, but there are many other antibiotics that are being used. Vasant? the complexity of veterinary agricultural antibiotic usage. What else we can do? How can we convince people that this practice needs to change?
Sir, as has been discussed, I think it's a very difficult task, and it's not really easy to convince at even at the state level and across our country and across the world. How should we not using antibiotics, especially in the poultry and other agricultural farms? So it's a really challenge, sir, and we have seen that. I think you yourself have done the homework of a lot of these, the meats where they were, having resistance, antimicrobial resistance to even higher end antibiotics. So I think the only way forward would be educating people and educating the, paramedical, this agricultural fields and the veterinary fields, how we should be not using restricting, because our futuristic children will only land up with more and more resistance of these antibiotics, and there will be no antibiotics left. So it's a very difficult challenge, sir. I don't have a real answer, but we have to work on this, sure.
We have two important organizations. We have got APUA, a global initiative to tackle AMR. We have got AMR Declaration Trust, an Indian initiative to tackle AMR. Now, how important is global collaboration? Pierre, you are there. How important is for us and several other organizations, countries to collaborate to tackle AMR?
Oh, it's a complex question. I think
Pierre, your signal is very weak. Your signal is very weak.
Oh.
Voice is breaking.
Sorry.
Oh, now it's okay. Now it's okay.
Okay, I was saying that your question is complex, and I think the kind of meeting you are organizing today is part of the answer. I think we have to share ideas, we have to share initiative, and we have to share the solution, like the guidelines we talked before. So I really think we should collaborate more, and maybe to involve more the people that are involved in the monitoring of resistance in the environment, and also the veterinary fields. And I think it's still a caveat in our organization that we don't have so many people from these fields. We should try to involve them more in our actions.
Yes, Gabriel, WHO is doing a good job in collaborating with the countries, but how can we make it stronger? How can we make the countries come together?
Yeah, perfect. That was, thank you very much. That was I was thinking too in my participation. The global collaboration made people hear about the problem. 5 or 6 or 7 years ago, nobody knows about it. Nobody, but many people were not aware about the problem. WHO with the national action plans and with the law regional, for example, in our area where we are collaborating as international consultant in the Pan American Health Organization, for example, most countries or all the countries now have the antimicrobial stewardship programs as mandatory in the national action plans. So suddenly all people have the need of beginning to implementing and strengthening their antimicrobial stewardship programs. Now it's not a matter of trying to convince or to evangelize the people of the importance. Now are mandatory. So many people has to do that, and the governments are pushing them. We as Pan-American health organizations are supporting them with meetings, monthly meetings with different countries, but convened by the Ministry of Health. So there's no mystery, as Heyman and Pierre said. With the Ministry of Health convinced and with the legislation towards the implementation of measures, both at hospital, at agriculture, veterinary, and community levels. And our groups, all our groups, with the willing of support, the educational and the strengthening of that meetings, of that initiatives. The things are running faster and faster. Even we could not imagine this 2 or 3 years ago. So I think that we are doing well, and the countries and national governments might have take the cost, the bag, they carry the bag about doing that without stopping. We will have problems, of course we'll have problems. We have problems of ignorance, we will have problems about interested of our pharmaceutical interests, but if we are going this side, this way, we will succeed. I'm very optimistic, as my partners are.
Yes, anyway, we need to be optimistic. Countries need to come together. We discussed for almost 1 hour, 50 minutes, and just during the initial part of the planning of the meeting, many people ask what exactly a fireside chat is. Just look at the Zoom screen, you will see participants, the panelists joining, leaving, joining back, and that's the fireside chat. The only person who will be here all the time is the coordinator. A very interesting discussion anyway. We have got few more minutes. The future of antibiotics. We can't have an AMR meeting without the discussion on future of antibiotic. And ever for last 2 decades, we have been discussing about future of antibiotic. How can we have new antibiotics? We have a lot of new antibiotics, over the last few years. But still, we do treat infections where even a single antibiotic is not working. In my practice, I do come across patients with not even a single antibiotic is working. In fact, last month, AMR Declaration Trust brought out a book called as No Option, where 17 doctors explained in very simple terms how, on a typical examples for public to read, what exactly no option scenario is, what exactly doctors mean by no treatment option scenario is. It's very scary. But still, later, the next 17 chapters from scientists from across the world explain what they are planning, what they are doing to solve the AMR crisis, the new antibiotics, new diagnostics, new vaccines, new other technologies. So what is the future of antibiotics, other technology, and what's the future of the world in the presence of antimicrobial resistance? Priscilla?
I was hoping you wouldn't ask me that. There is this caricature, I think all of us have seen it. Over the years, you start in the early 1900s, here, take this route, and then the antibiotics come in. And I think we're heading soon towards the scenario where finally we'll have no antibiotics and we'll say, oh, here, take this route. So, well, not to be a doomsday prophet, but yes, we have to take, I think, a major, have to have a major action plan to be able to judiciously use the antibiotics that we have now. Having said that, yes, I think we are heading into an era, if you're not careful, where we will indeed have patients who we will not be able to treat. And that, I think, is that is going to be a tragedy for all of us. Well, looking positively, yes, hopefully we'll have, vaccinations coming up in a big way. We will have other preventive methodology, which will help us to be able to deal with these infections. And maybe we will look to other adjunctive therapies as primary modalities of treatment rather than antibiotics alone, because I think, there is only so many fungi you can kill to get antibiotics that we have. So I think we need to look at innovative modes of treating patients other than just antibiotics alone. I believe we need to modulate the host as well. I think that's a thing that we have not explored, and that needs to be looked into further. So we need innovation.
We need innovation. Yes, Vasant, innovation in AMR.
I think I think every country or every region have to have their own specific, and the government, and I think everybody has to pitch into what is the need of their country as of now. Because I think for us, I think our problem is more of gram negatives and we are hardly having any antibiotics, and we are losing on the last battle of the polymyxins also. So I think we'll have to have more research into tackling our bugs and having more newer molecules. And unless we have that, I think we are going to have a big problem ahead. And as Priscilla said, we'll have hardly anything left. So I think definitely we require to highlight this issue at every level, that more research required to have more innovations and more newer molecules to combat the resistance of those individual countries. Like for example, our problem is completely different from the Western world. So I think unless we get into this, we'll not be able to provide.
Yamuna, still there?
Yeah, I'm there, sir.
The question is innovation.
That's a very tough question on innovation and prevention of antimicrobial resistance. I don't know, hope for better and new drugs and prevent the spread of antimicrobial resistance. So at least the treatment burden of multiple patients comes down and we are left off with few patients to treat rather than treating the whole lot of patients who will get an antimicrobial resistance. Like we are heading towards a future where we would run out of antibiotics in spite of newer antibiotics coming in place. So we need to start working on the prevention and control aspect and also judiciously using the antibiotics.
Yeah, because innovation is an interesting topic. It gives us positivity rather than talking about death. AMR is quite often a negative topic, but we need positive discussion. Today I told my wife, okay, I'm having another webinar. She asked me, oh, is it AMR again? I told yes. She told me, I married you 25 years ago and you are talking about AMR, and even today it's AMR. So I asked her back, does that mean, should I change the topic? Oh yeah, change the topic. So I asked her, are you thinking of changing the husband because you married me 25 years ago? So it's an interesting topic. Still, we are keeping on discussing about the topic of AMR. It's never boring. We were young at that time and quite, the faces, the same faces, but the appearance of change. It was quite a negative topic at that time, and now it's becoming quite a positive topic as well. A lot of innovation in the AMR world. We had a wonderful discussion, almost 2 hours, panelists from across the world, attendees from across the world. We covered almost all important aspects of the AMR. And thank you all very much. Thanks the team from the APUA team, Perry, Heyman, Gabriel, and we have got very interesting panelists from India, Osi Abraham, Vasant, Arvind, Priscilla, Sunita. And thank you all for the wonderful discussion. Let's in future let's have more collaborative and discussion on more topics. And thank you attendees from across the world for participating in this webinar. Thanks a lot.
Thank you very much, Abdul, and thank you to all the colleagues from India because it was very, very fascinating. Hope we meet again.
Thank you
very much.
Bye, everyone.
Bye-bye. Thank you very much
Bye.
again. Congratulations to everybody there.
Thanks for great moderating. Bye-bye.
Thank you very much.
Wonderful.